Hi, I'm Julia Resnick from the American Hospital Association. In July 2020, AHA's The Value Initiative partnered with the Advancement League to host a virtual event for emerging health leaders, where we discussed how to create a more equitable path forward from the COVID-19 pandemic. In this video, you will hear insights from 4 hospital leaders about their organization's efforts to address health equity and the social determinants of health during COVID-19. The Advancement League's Chelsea Perry is joined by Denise Brooks Williams from Henry Ford Health System, Leigh Caswell from Presbyterian Healthcare Services, Desiree de la Torre from Children's National Hospital, and Matt Primack from Advocate Condell Medical Center.
All right, welcome back everyone. I hope we still have most of you all with us, and we'll go ahead and get started with our next segment. My name is Chelsea Perry, and I am the head of community of the Advancement League, where I've spent the better half of the past year and the year before doing what we have coined road trips across the country and have now taken a virtual format. So if you've had the opportunity to join us in cities like Detroit, New York, San Diego, Baltimore, welcome back. And we're excited to share this opportunity with the American Hospital Association for our first ever virtual road trip. So thanks to our partners there. We have an outstanding group of hospital leaders joining us to share what their organizations have been doing to address health equity during the COVID-19 pandemic. And so before we roll into our speaker introductions, I'd like to also just thank the folks that we have here now on the call for the time that they're going to spend with us for the next 30 minutes. So thank you all for joining us for the Silver Linings panel entitled How Hospitals Are Addressing Health Equity during COVID-19. First speaker we have with us today is Denise Brooks Williams. Denise, can you give us a wave? All right. Denise is the Senior Vice President and Chief Executive Officer of Henry Ford Health System North Market. Among her many honors, she has been recently appointed by the Governor of Michigan to the Michigan Coronavirus Task Force on Racial Disparities. Thanks for joining us, Denise. One of the first questions that we have for each of you is a question around the disproportionate share of healthcare burden borne by communities of color. History has shown us that in any crisis, especially healthcare crises, there is a disproportionate effect borne by communities of color. And so we're interested to first hear from you about what your organizations are doing to address the fundamental issues and social determinants of health that plague these communities prior to the advent of COVID, and where will your organizations focus future efforts to address these inequities exacerbated by COVID. So let's start with Denise, and then we'll follow with Leigh, Desiree, and Matt.
Hi, Chelsea. I think absolutely, as you have said, what we saw in Michigan, unfortunately, was that the health of our community and knowing that we've had disparities and really focusing on social determinants of health for a long time, we really found ourselves exposed during the pandemic in the sense that our systems were not as they normally have been. And while we have a lot of programs that were in place, we were not finding that when we closed access that we could really maintain what was needed to keep the community healthy. And we saw everything, quite honestly, exacerbated. So therefore, people not being able to get to the care that they needed, and the vulnerabilities that were already existing with our communities really being exacerbated because they were already in a position of not being in the mainstream healthcare environment. And our task force, quite honestly, as you described in the beginning, really immediately, and I think fortunately, came to be as a result of the outcomes that we saw. So not only did we know that the disparities existed, we saw how they would play out in an environment where people were faced with something that really worked on their systems in a way that exploited the fact that they were already in a vulnerable position.
Next, we have Leigh Caswell. Leigh, give us a wave. Thank you. Leigh is the Vice President of Community Health at Presbyterian Healthcare Services in Albuquerque, New Mexico. Leigh and the Community Health Program were awarded the Spirit of New Mexico Award, where she was recognized as Albuquerque's Business First Woman of Influence and also a 40 Under 40 recipient. She is also a Robert Wood Johnson Foundation Culture of Health leader.
As a not-for-profit health system in New Mexico that's been around for over 110 years, our system has really strong relationships with our state government and our community service providers, and absolutely has stepped up to provide health care and to partner with the state on the response to the COVID pandemic. As far as how we addressed equity and the disproportionate burden on communities of color for health inequities, we really have taken our community health assessment and implementation plan seriously, and we do everything we can to listen to the community and respond, recognizing that we really want to build on their expertise, build on what's working well with them, while leveraging our resources to really increase the impact that we can have. So we do, a lot of work investing in coalitions and public health infrastructure and community organizing in order to really not duplicate what's happening and really build on that community expertise. We have a strong anchor institution strategy, so we've partnered with other anchor institutions in the community and really looked at how do we hire and who do we hire and how do we increase our local procurement and really focus on that and what is our impact in the community by just being physically located there and how can we do better. We also really look to address the social needs of our patients, and so we have really built out our community health worker team in our system. And also, when you look at health inequities, behavioral health is, really our biggest priority that we've heard from our communities. So we're also looking at innovative models around peer support specialists and really how can we support our communities in a different way. And we've explicitly acknowledged health equity as the foundation of our work and integrated it into our quality plan and really prioritized it as our work.
Next, we have Desiree de la Torre. Desiree, give us a wave, please. Desiree is the Director, Community Affairs and Population Health Improvement at Children's National Hospital in Washington, D.C., where she leads the organization's Community Health Improvement Strategic Planning process. She is also the chair of the Commission for Health for the County of Montgomery County, Maryland.
Hi everyone, I am Desiree again, and it's a pleasure to be with all of you. It's great to be with such wonderful panelists today and the great speakers that we had. Thank you to the American Hospital Association and the Advancement League for giving us all this opportunity to be with all of you today. For us, the social determinants of health at the Children's National Hospital, which is a children's hospital in the Washington, D.C. region, we get patients from Virginia, D.C., and Maryland. And we recognize that many of our families are experiencing some of the same things that in your urban cities are experiencing too. The disparities in health and wealth and education, even from communities that are only a few miles apart. And so we've been very focused for a number of years on making sure that we're screening our patients for the social determinants of health and connecting them to those resources. And like Leigh, we are also part of our collaborative called the DC Health Matters Collaborative that came together to do a needs assessment and the implementation plan like she described to focus on the needs of our community. And connecting to social resources was one of the greatest needs. And so together we came together to implement a tool that connects families to resources, not just our hospital, but to all the other community-based organizations and healthcare clinics in the community. And that ability to connect them to those resources, one, giving the tools for our social workers and our physicians and employees to be able to find these resources from food security to legal to housing and employment, but then actually connecting them to those resources and using community health workers to connect them to those resources. And we also know in COVID and as a result of COVID, we have to continue to focus on those policy and system issues. And from a policy side, focusing on some of the opportunities around housing, transportation, early childhood education. These are some of the policies that will impact the health of our community. And so putting on laser focus on some of those policies and system opportunities is what we've been doing and what we'll have to continue to do as a result to address the social needs of our community.
And last but not least, we have Matt Primack. Matt, hi. Matt is the president of Advocate Condell Medical Center, part of the Advocate Aurora Health System, where he is responsible for executive oversight of the hospital. In his prior role as president of Advocate Christ Hospital in Chicago, Illinois, Matt was responsible for several violence prevention and workforce development projects.
Good afternoon, everybody. Hopefully everybody can hear me. My name is Matt Primack. I serve as president of Advocate Condell Medical Center, a large Trauma 1 center in the northern suburbs of Chicago, and part of the 28 hospital system of Advocate Aurora Health. And it's a pleasure being here, and a big thank you to not only the AHA, but also the 300 plus folks that are on the call today. It takes numbers to make change, and clearly by these types of events, there is power in numbers, and so hopefully everybody can go home and tell 10 people what happened today, and now we have 3,000 people telling the same story. So it's going to be difficult as last in line to actually add new initiatives to what was already discussed prior, but want to get a little bit tactical. We've spent a lot of time in the city of Chicago and in the state of Illinois partnering with our local legislators. We also have done something interesting in the state, which I'm very proud of, which is a bit unique, is we've actually partnered between organizations. So the academics, the privates, the nonprofits, we form many coalitions within the industry to pool resources and partner with our local community-based efforts, which is, from what we've heard, relatively unique in the other 50 states. Two very tactical things that we've done in the organization is we recognized in COVID very early that testing was going to be one of our major concerns. We actually stood up mobile testing facilities, both in trailers, in mobile vehicles, and in tents, and have specifically targeted some of our high-risk areas in our underserved populations. And we spend a day, a 2 or 3 out in these communities, bringing all of our testing resources out there, recognizing that transportation could be an issue, recognizing that other resources to assist folks getting to our originally planted testing facilities could be difficult. So that's been well received. And secondly, we've talked about community health workers, we've talked about community outreach and community wellness. We've decided as an organization that we're going to stick all of those people in one box and shoot them out into these underserved communities as educators. The things that often in our industry we take for granted, hand washing, masking, social distancing, which we can put on a billboard and we can send out an email, but for many of our underserved communities, though, that message doesn't always reach them. And so we've gone remote and gone into schools, gone into churches and faith-based organizations, and really taken education external to the organization out into the communities. That's already been, well received, and we believe to be pretty successful in beginning to flatten some of that COVID curve.
That's extraordinary, and it's so good to hear from nearly each of the 4 time zones in the United States about how healthcare systems are approaching these problems similarly and perhaps different in terms of innovation from each of those spaces. And so, Matt, while you have the floor, actually, let's stick with you. I'd like to hear a little bit more about some of your work as both having led a large urban hospital in Chicago and now a suburban one. What are some of the lessons from both of these experiences that are informing how your healthcare system, Advocate Aurora Health, will address the social determinants of health related to COVID?
Thank you, Chelsea. Always now a pleasure to go first, but now I'll have to see how that balances out. So I've got a few things that I want to share with the group, starting with this. For those of you that are on the call in leadership roles, without making this an organizational priority, where everybody is rallying around this, from your medical staffs to your teams to your external partners, you will be running uphill in the sand. And so we learned that by prioritizing this, by over-communicating this, we could actually recruit the interest, the energy, the excitement around this. So organizational priority is a must. Next is, we talked about all of our resources of our community health workers, our community outreach and wellness leaders and teams. We had to align internal functions to specifically address all of our disparities and all of our opportunities in the community. And until we aligned those efforts, we were sort of bouncing in a lot of different directions. Third, we typically in healthcare spend a lot of time looking at data. We're really good at pie charts and line graphs and you name it. We sit in boardrooms and stare at data. But what we recognized early is that these types of efforts and identifying the opportunities don't always come in PowerPoint presentations. And so we began to make a specific effort of getting out into the community and asking and talking and learning. That was a big lesson learned for all of us. External partnerships are critical. Again, the big academics and the big hospitals, set up an initiative. We're going to launch an action plan. And not always in this situation does the big hospital always know best. So we've begun to not necessarily lead initiatives, but partner with frontline community-based efforts and saying, how can we help be part of your cause? Another big learning opportunity was for us not to underestimate the power of the faith-based community. We found that when we partnered very closely with our faith-based leaders and our congregations and our parishes, that we could accelerate our movement much quicker than if we were to do it simply in an isolated fashion. And lastly, we often in healthcare, as everyone knows, we look at wins, we look at successes, and not always in this world do we get those measurable wins, but it's about programmatic advancements, it's about enhanced partnerships. And so we've encouraged even ourselves to say, let's not look at data for success, which is unique with us in healthcare, but let's talk about what impact we're making the community over the long run.
And I think that's huge, Matt, and thank you so much for that point, especially about not getting stuck in analysis paralysis and getting out into the communities and learning from the folks on the ground. Leigh, I know that you're embarking on similar efforts where you are in Albuquerque, New Mexico, and so we'd love to hear from you about how your organization, Presbyterian Healthcare Services, is responding to food insecurity in local communities and how you're ensuring that families don't go hungry.
We have had a really strong history of addressing food insecurity as a part of our community health implementation plans. And a lot of it, we look at our food insecurity strategies and kind of from a public health lens, right? So we're looking at individual behavior, but also policies, systems, and environments, right? If we're going to be effective, we need to really be addressing the food system at all these levels. And so a lot of that requires us to think through how are we impacting local economy. And I think addressing and investing in local food systems is a way to help ensure that we're building sustainable local economy and also increasing access to healthy food. So we're meeting multiple of our priorities. So we've done things within our systems because we want to be responsive to our care teams and the needs that they have. And so we've created a food pharmacy. So our providers who are finding that their patients are food insecure are able to refer patients to our food pharmacies sites where the patient can come once a week for 6 months and receive at no cost fresh, oftentimes locally grown produce and healthy staples. And so that is one of our big initiatives. And we also have a mobile farmers market, and I would say that where we purchase all of the food from local farmers. And that is one of our models that we're struggling with right now because we've had to adapt it from a choice model to a more of a community supported agriculture, like farm share model. And we're just not seeing a lot of people out. And so we're thinking through now, like, how are we adapting these programs? One of our programs that has been utilized quite a bit now is our free healthy meals program, and this is the USDA the at-risk and after-school summer meals program that we provide in our cafeterias. At most of our hospital cafeterias, we provide this program. And in one of our rural hospitals, it basically means that if you're a child under 18, you can get a free meal at any time, no questions asked. And at one of our rural hospitals, pre-COVID, they were seeing maybe 150 kids a day receiving free meals during the summer. And if you can imagine these little tiny cafeterias, like what that actually means, the amount of children who are coming. And I would say that post-COVID or during this pandemic, we've seen a 600% increase in the utilization of these, the free meals program. And we've had to adapt it to be a grab-and-go model. So we're setting up tents outside. The staff are really adapting the way they're doing this. We're in the process of shifting our intake process, so we ask every single patient about social needs. And so we're working with an organization out of Chicago called NowPow that we've integrated into our electronic medical records so that when we're when we're asking patients about these social needs, we actually have resources to connect them to. And then we do a ton of investing in the community to build that local economy. With local, to help to build aggregators and, food hubs, because we know that there needs to be more infrastructure if an organization like ours is going to purchase more local food. So a tremendous amount of other types of partnerships, like with Meals on Wheels, to help them purchase more local produce and increase the number of meals that they're able to provide, investment in our food banks and food pantries. So we have this really big strategy. So thanks for the time to share a little bit about that. And we'll continue to adapt and continue to partner and really recognize the importance of responding at this time. Thank you.
Absolutely. And just congrats to your team on the success of the pivot and just the adaptability. I think that is huge during this time and going forward. I think healthcare has historically been picked at for not being as nimble and adaptable as your team has demonstrated. So good on you. A little bit more about adaptability. Desiree, I know that you're here in the Washington, D.C., well, here where I am, in the Washington, D.C. area at the Children's National Hospital, doing a lot of work around how COVID is affecting children and getting out into the community and educating other stakeholders in hospitals about the effects of the pandemic on this particular patient population. So can you talk to us a little bit more about the education that your team is doing in the community regarding the spread of the virus, providing education around perhaps the impact of returning to school, and how can children's hospitals specifically partner with other hospitals and community-based organizations to support?
Great. Well, thank you for that question, because it's an important question as we think about COVID-19 and how it's impacted our patients, not just from a children's hospital, but all our patients across the nation. For us, we knew that we wanted to make sure our families were educated about coronavirus and COVID-19 and explaining what that means, right? Health literacy is one of our priorities of our community health needs assessment. So being able to communicate what does it mean, what do you do to protect yourself, was very important. And so we did that by coming out into the community virtually and partnering with the school systems, with local community-based organizations to get this information out virtually in both, in English, Amharic, and in Spanish to ensure that we're reaching all of our families about this information. And then partnering with our school system has been key. And so for our hospitals, we heard it from Dr. Blackstock and Monica, and from our panelists today, how partnerships are critical to really improving the health of our communities. And so partnering for us really meant, and we have been doing it for a number of years, of focusing on health and education, recognizing that our kids spend most of their time, we're spending most of their time in schools, currently experiencing distance learning, and that future is still unknown, but how health and education are critical partners in creating a healthier community. And so over the last couple of years, we've been trying to develop a school-friendly hospital. And so what that means is, as a hospital, how can we be a better partner with the school system, with the education education system. And for the past years, we've operationalized the school nurses within schools, we've had health education in schools, financial literacy, in addition to a number of other health education programs. But with respect to COVID and thinking about returning back to school, and if we're not returning back to school, that impact that it has on children and families is critical. So how do we partner with the school system to ensure that we're educating the school systems on what are safe ways to open schools? Because as a healthcare system, we've already been experiencing that. And then how do we support our families? I forget who of our panelists today, but focus on that mental, social, and emotional well-being of our families, and providing the services to our families to address the anxiety that our children are experiencing, that our parents are experiencing. So providing the services to partner with our local early childhood education centers to make sure that we're providing those services to our community. And then finally, partnering with our government agencies. One thing that I urge this group to do today that is very timely is to make sure that you encourage yourself to complete the 2020 census. The census will drive a lot of what happens, the financial implications of that over the next 10 years. And we know COVID-19 will have a large impact on our children and families over the next few years. And so completing the census is one way to ensure that we're doing what needs to be done to ensure the success of our community. The census determines the funds that we dedicate to schools, to Medicaid, to healthcare clinics, to roads and buildings and libraries. So I urge you to take the time. You spend time on your Instagram, your social media, or at work for more than 10 minutes, and it'll take you less than that to complete the census. So I encourage all of you to take the time, to encourage families especially, because what we found is children under the age of 5 that are the most undercounted, especially among the Black and Latinx community. So with that, I urge you all to make sure that you partner with your communities.
That's huge. It took me surprisingly only 2 or 3 minutes, so I'm happy I got that done and out of the way. And thank you for encouraging everyone listening to make sure that they get that done for their own communities. And so just expounding a little bit more on that marriage between private and public sector, I want to now move to a question for Denise, who, as you all remember, was appointed to the Michigan Task Force on Racial Disparities, focused on equity during this time and after the coronavirus is no longer, hopefully. So Denise, could you tell us a little bit more about your function on the task force and what that looks like? I know it's something sort of a first of its kind. So
one thing I want to do, Chelsea, too, is back up, because I didn't, being first is a deficit, right? So I didn't give credit to Henry Ford Health System. Obviously, what I would say, as I said, is from a baseline perspective, we've always been focused on the social determinants of health. Obviously, our positioning being in an urban environment, it's core to what it is that we do. But it is true that Michigan, and perhaps not like my colleagues, maybe Illinois, found ourselves really quickly in the pandemic kind of shifted in our focus, because we couldn't rest on what it is that we've done historically. We really did come together as a statewide coalition around why does the data show us that persons of color, in particular African Americans, are faring worse from a mortality perspective. So we immediately had to really set aside, right, all the things that we were proud of, which are amazing things that we've done in women's health and from a school-based health perspective, from food insecurity, housing insecurity, a lot of the things that my colleagues spoke about, and focus on what could we do in that immediacy to try to turn that curve. We did testing, as we've all said, but we did testing. I think it was someone else who spoke about mobile testing. We also had to create environments as we found people that were afflicted with the virus that didn't have homes. So we created really unique partnerships at that time. Of course, our hotels were empty. So we were able to partner with them and find housing support for those that were without homes, but also relied on community health workers, I think, which was also stated earlier, and connected them in 2 ways. One, so that they could be a resource to connect people with providers, because access, as I mentioned for us earlier, became a great divide very early, because our vulnerable communities didn't really adapt to telehealth as quickly as some of our other communities. And so where we didn't have Wi-Fi, which plagued us in the community, we had to figure out how to get people deployed to homes so that we could make sure they understood the testing. And absolutely being able to be in a safe environment was critical for them at that time. The last thing I would say from a task force perspective that we have and continue to focus on is policy change. So what is it that we can do different around requiring providers and awareness. Our governor probably made headlines in other parts of the country when she put an executive order in place last week to require implicit bias training for all of our licensed providers in the state. And so we think that will go a long way, and I would encourage others that are listening and that are here on the panel to look at what can you do from a systemic perspective, because what I've heard, right, which is very encouraging, is that in a routine environment, we all do the right things by the communities that we're serving. And we probably have all enjoyed great lifts in the data to say that we could have an impact. But what we saw during this pandemic is that we need to do more. And it will take every partnership relationship that we have in and outside of our states and respective areas to really figure out how we create healthy communities and get the health status that we need so that no matter what, unfortunately, the next unknown condition is that we have to face, you don't have any groups of people that fare worse, that we are all at an equal opportunity to survive and thrive.
Absolutely, Denise, and I think that was a quotable, so I hope someone caught that for their social media later. So just with the remaining time that we have left, I wanted to pose one more round-robin style question to the panel here, and just for you to leave us with some predictions and perhaps a leadership lesson that you've learned now just watching the industry and your own organization's response to COVID-19. Can you tell us, how do you see the role of hospital systems changing now in response to the COVID-19 virus and how we approach health?
I will admit that our entire organization has spent a tremendous amount of time on what it means to be a leader in a time of crisis, what it means to be resilient, what it means to continue to inspire and engage the people who work in and around you on a daily basis. But I think more importantly, that was a complicated question, Chelsea, because you've sort of taken COVID, leadership, hospital, healthcare, and disparity and inequity, sort of smushed it all into one question. But I think what we all, I think as leaders in the industry have to be able to do is think differently and act differently. And we have been in the past in an industry that has been very slow to innovate. We may be very innovative on the clinical technology and the clinical advancements, but in the overall broader care delivery model, we sort of go slower than other industries go in transitional type periods. And so I think that's a huge lesson learned, that if we're really going to attack COVID in an inequity situation, we need to be nimble and agile to think and act differently.
I couldn't agree with you more, Matt. Thank you so much. I reflect on the last several months of COVID-19, and in addition to that, the racial injustices that we are experiencing across the nation, and the great interest across the healthcare system, even, for example, the White Coats for Black Lives movement in some of our hospitals. All of that is very exciting for us to come together to address these health inequities that we've been experiencing for a number of years. So my question for all of you is, how do we reimagine healthcare? What does that look like? And the theme that I've heard from, at least from the panelists today, including Dr. Blackstock and Monica and my colleagues here, is that we are advocates for our patients in our communities. And so don't limit yourself to an administrator, to a physician, to a nurse, to a community health worker. We are advocates as well. And so I encourage you to not only work within your own silos, and I saw a question about how do you make sure you connect the community health needs assessment to other things, is to break down those silos within your organization. Be a part of the finance conversations, because they're critical. Your voice is critical to that piece of it. Be a voice in your community. Join commissions and community-based organization boards and things like that, where you're learning about other things and being an advocate for not only health, but for everything that impacts health. And so I encourage you again to be advocates.
Yeah, I would echo some of this. What I've been amazed by is how agile we've been able to be in expanding telehealth, being really creative about how we address inequitable access to internet access, and how are we actually reaching out to our patients. And so we've been moving quickly, and it's really, really amazing. And also, that we can make bold statements as leaders and as health systems around anti-racism and inequities, and that it's okay, and that we have to, but that the other leaders are going to be okay with it, and our patients are going to be okay with it, and that we're hungry for that, and we're hungry to do the work that needs to be done. And I'm just so grateful for that. I'm so grateful for this moment in time to elevate this work that we know is so important, and to really have the backing of our states and community partners and other health system leaders.
So I would definitely echo what everyone else has said. It's almost as if, I think what Matt said, I was on a roll. And I feel like that's what our community is on. It's on a roll. I mean, you honestly feel from our state level, definitely the city of Detroit, and I think all of the other communities where we sit as a health system, you're seeing two things, right? Everyone is rising to the occasion. And not allowing this to be a moment in time, right? The racial inequity component of this, which obviously health is a piece of that, but it really is our education system fabric. It's what our businesses are doing. It's how we're choosing to look at governance. So I think that our dialogue is significant. And I think as healthcare leaders, we have a huge role to play, because COVID kind of was the catalyst for the conversation. But as we know, we shifted really quickly to the injustices and inequities that we're experiencing broader in society. And I think that broad lens is the one that's going to be transformational, and it's going to include healthcare. And I think we do, as my colleagues have said, have to figure out what are the partnerships that we can forge at this time, and how do we make sustained change? Because ultimately, if all of our systems rise and are better. So if our education systems improve as a result of this, if our healthcare systems improve, our financial systems improve, our housing environment improves, we know that we're going to have healthier communities. And when we have healthier communities, we're going to see equity actually be an option, because you can't just be healthy and have no job. You can't just, have a job and education and not have health. So they're so interconnected that I just love the idea that would say together, if we stay focused and we look at really what it takes to create healthy communities, which all of our health needs assessments, I think, guide us towards that. If we're focused in that, I think we're going to see tremendous transformation that will be sustained.
Well said, everyone. And I know us at the Advancement League especially believe that the future of health is together. And I know I can say the same for our partners at the American Hospital Association and everyone on this call. So I wish I could keep you all forever. This has been such a powerful discussion, but I'm getting the nudge. So I just want to thank you again for your time here today and imparting some wisdom and really some ideas to our audience of emerging healthcare leaders and existing leaders. So thank you so much, everyone.